All right, good morning. We hit the 30-second mark, so I guess we must be ready to go. First of all, good morning. My name's Ken Thorpe. I'm chairman of the Partnership to Fight Chronic Disease. Also part-time, actually supposed to be full-time professor at the Emory University in Atlanta. So good morning. It's a really important topic in terms of a looming challenge and impact on access to our healthcare system. A government price-setting system instead of policies is going to come closer to reality. A couple of administrative details. As you have hopefully seen on the invite around the room today and already on social media, we'll have live tweeting from the hashtag #MoreThanAList, all one word, and welcome you to join us and share your thoughts and photos. We do plan to take audience questions and have passed a mic available during these segments and would welcome you to raise a hand once you have the mic to share your name and organization. So with that, let's go ahead and dive in. We're going to hear from several experts today on the breadth of the impact of the Inflation Reduction Act on Medicare price setting and what impact it'll have on healthcare and the pharmaceutical ecosystem, beyond the impact of the 10 initial drugs that are on the selected drug list. Our discussion will look at these issues with several lenses and shed some light on both the short and long-term consequences which have already taken hold, even in advance of CMS's release of the initial drugs for price setting. Some critical things to understand about these upcoming changes are that the pricing model simply cannot work to lower Medicare spending without cutting access through utilization, review, and tactics, and potentially rationing. Many of the drugs likely to be on the list are not expensive medicines, but they do treat a lot of people. That means that access barriers need to achieve savings will ultimately affect a lot of Medicare patients. Some key things to keep in mind. One, Medicare is targeting the drugs on which it spends the most. And we know that spending is a simple equation of the price Medicare pays for the drugs and the amount of drugs taken. So many on the list may involve drugs that aren't particularly expensive, but are used frequently to treat millions of beneficiaries. And we have to just keep in mind that if you look at Medicare spending in particularly, well over 95% of spending on Medicare is linked to chronically ill patients and patients with multiple chronic healthcare conditions. Predictions of the potential list of the drugs. The first 10 include commonly used drugs. These medicines cost Medicare an average of about $1,800 to $4,400 per beneficiary over a year. So they're really not expensive medications, but they could make the list because a lot of patients take them. That's important to keep in mind because a price cut alone isn't going to generate the savings the government is potentially counting on. Instead, Medicare is going to have to achieve these savings through reductions in utilization, and that means reducing patient access. A lot of people's access to some of the most utilized medicines covered by the Medicare program. We anticipate that some of the therapeutic areas that will be initial parts of the damage are blood thinners, certainly type 2 diabetes, leukemias and lymphomas, rheumatoid arthritis, breast cancer, prostate cancer, among others. The drivers of this price setting are largely at odds with other administration priorities like the Cancer Moonshot, the Orphan Drug Act, which is widely supported in Congress, and many other important public health efforts that we'll discuss this morning. PFCD has long stood for comprehensive and sustainable solutions that protect both overall health outcomes and pocketbooks of people living with one or more chronic conditions. The path of the IRA does really nothing to address the pervasive access barriers that insurers and PBMs place on patients, including high out-of-pocket costs. And our theme is always focusing on out-of-pocket costs, what patients actually have to pay for medicines. That drives utilization and adherence. Actually, the $2,000 cap off script, the most important part of the Inflation Reduction Act. The rest of it is a budget exercise. Although this shortfall for patients in the absence of any measures to curb access restrictions for seniors with chronic illness, again, 7 in 10 Medicare patients have at least 2 chronic conditions, and we talked about how much money is spent on it. So to address affordability is essential to more directly access and address rising costs at the pharmacy counter, what patients pay out of pocket, and pass these savings along directly to the people relying on medicines for their health, not to alleviate federal budgets. Another major concern with the legislation that leaves older Americans, people living with disabilities, and people with chronic conditions at serious risk of increased health disparities. We know that the underlying prevalence of these chronic diseases varies widely among people of color relative to non-Hispanic whites, so it's going to have a disproportionate impact on different populations in this country. We know that this is a major concern, and we have to explore how the drug pricing regime will affect differences in health equity and health disparities. Clearly, a lot more to think about here. We have two great panels. We're going to be led off by just a wonderful keynote speaker who you all know. He's a national thought leader, has been for some time. Even though he's only 35 years old, he's done a lot. He's done a lot already. We're just really pleased to have Scott Gottlieb here. He's a physician, served as the 23rd Commissioner of the U.S. Food and Drug Administration. Dr. Gottlieb's work has focused on advancing public health through developing and implementing innovative approaches to improving medical outcomes, reshaping healthcare delivery, and expanding consumer choice and safety. He serves on the boards of Pfizer and Illumina, is a resident fellow of the American Enterprise Institute, and a partner in the venture capital New Enterprise Associates, and a CNBC contributor. So he's going to have a real unique insight on the Inflation Reduction Act's impact on investment streams, among others. So we're very, very pleased to welcome Scott. Well, thanks, Scott, for setting the stage, as sobering as of a stage that it is. Again, I just think reflecting on some of his comments, that this was a very frustrating time as you watch this, because it really is a policy a policy change that really doesn't address any of the underlying issues. It's easy to come in and just do price regulations and say you've solved the issues of the drug channels and change and some of the disincentives, and it really does nothing along those lines. It really is just a pretty arbitrary set of hammers coming in to do price regulations. So you heard sort of the big picture from the investment side and some of the structural issues. We're going to move to our first panel now, really focusing on the unintended consequences this will have on patients. So I'm going to introduce the moderator, who's fortunately sitting very close here, Sue Peshin. She's the president and CEO of the Alliance for Aging Research, the leading nonprofit organization dedicated to accelerating the pace of scientific discoveries and their application to improve the universal human experience of aging and health. Their vision is to create a culture that respects aging as a greater good and values investments that advance independence, dignity, and equity. She has led the efforts to increase federal investment on aging research, raise awareness of geriatric cardiovascular disease, develop an older patient and family caregiver research engagement network called, I love this, NERDY to me, talk nerdy to me, very, very clever. She serves on the boards of Heart Valve Voice, U.S. National Health Council, Committee for Advancement of Respite Research, Preparation and Treatment, Equity Coalition, Voices of Alzheimer's, as well as Scientific Advisory Board for the UCSF Stanford Center of Excellence in Regulatory Science and Innovation. Also the Council on Convention, UMD Claude Pepper Older Americans Independent Center, Community Advisory Board. She served as senior roles at the Alzheimer Foundation of America, Consumer Federation of America, Hadassah, Violence Policy Center. She earned her BA in Sociology from Brandeis, MHS degree in Health Policy from Hopkins. I'm surprised that she's got the time to actually be here this morning, given all these wonderful things she does. So, Sue, would you please get our first panel going?
Thanks, Ken. Thank you. Okay, I'm going to bring everybody up with me here. Dr. Seth Baum is Chief Scientific Officer at Flores Research, and he also serves as Clinical Affiliate Professor of Cardiology at the Charles E. Schmidt College of Medicine at Florida Atlantic University. Erin Callahan serves as Chief Operating Officer at the Diabetes Patient Advocacy Coalition and Diabetes Leadership Council. Erin lives with type 1 diabetes. Tom McCoy leads state government affairs at the Chronic Care Policy Alliance and is Executive Director in State Government Affairs at the Nevada Chronic Care Collaborative. And Heidi Ross serves as Vice President of Policy and Regulatory Affairs at the National Organization for Rare Disorders. And all of their bios are in your packets. Okay, I'm going to start off with Erin. As someone living with type 1 diabetes, you rely on insulin for your health. The news makes it sound like insulin would be out of the equation when it comes to Medicare direct negotiation, because it seems all insulins went down to one price to the same amount per month. Is that accurate, or is there more to the story?
First of all, thank you. There we go. Thank you for that question. Thanks to everyone for being here. I was hoping that we would keep that sexy lighting on this hot topic, but here we are. Sue, you mentioned that insulin seems almost exempted or an exception to this. In fact, insulin, we've heard through the IRA that the insulin caps are going to be at $35 per person. We're certainly grateful for that. We're also very, very grateful for the $2,000 out-of-pocket cap because, as Dr. Gottlieb mentioned, there are kind of fake prices out there, right? And we know that there is a lot of debate over list price, net price, and even with the Medicare negotiations, they're looking at gross price as opposed to net price. So there are a lot of different numbers sort of floating in the insulin pricing and other pricing universe. Insulin is not the only answer for people with diabetes. I live with type 1 diabetes. I do rely on insulin every single day. If without it, I wouldn't make it until Sunday, and the days in between would be pretty miserable for me and everyone around me. That said, it is just one component of diabetes management, and that's only when you're talking about diabetes. People with diabetes ultimately have a propensity to develop other complications, other comorbidities. So insulin is not the only answer, despite what you hear all day, every day. Again, we're grateful for the $35 cap. We know that Lantus is on the top 10 list. It is exempt because of the generic alternative to that. But we want to make sure that the entire population of people with diabetes, type 1 and type 2, are going to benefit.
Thank you. Okay, Dr. Baum, in 2021, close to 4.5 million Medicare beneficiaries took 2 oral anticoagulants for the treatment of atrial fibrillation and other indications, and they'll likely be in the first round of drugs chosen for Medicare price setting. But these drugs only average around $4,000 a year per person, so they aren't the big ticket drugs we all thought would be on this government list. So why would those drugs be there? And is there anything that people living with AFib or other conditions should know if their doctor ends up having to switch the drug they're currently on?
Well, thank you also for having me here today. That's a very loaded and full question. There are many aspects to that. The simple answer is it's a budget impact decision that although the drugs are not that costly on a per patient basis, a lot of patients use them. I'm on one of those drugs. I'm on Eliquis, so not for AFib, but for something else. And I think that gets to the bottom line. We're all sort of, being misled or deceived by the complexities of this, of the IRA. Even Dr. Gottlieb said he has to refer to his notes, which I found very comforting, since I always have to, refer to my notes about this, and I'm trying to learn as much as possible. But the bottom line here is, how does this impact patients? How does the whole thing impact patients? You bring up, and we can discuss this a lot as we go on today, but you bring up the anticoagulants. We looked at the anticoagulants, Eliquis in particular, about a year ago. when when Eliquis was being removed from a very large formulary that had about 1 million patients on Eliquis, right? And we did a survey through Patch and the American Society for Preventive Cardiology, and what we identified was that about a third of these patients had major issues. Some of them had heart attacks and strokes, okay, when they had a non-medical switch of their medication. So one of the tools that's going to be used by our IRA that I think we can pretty much guarantee is utilization management on steroids. And if we saw already that people had strokes and heart attacks and other pretty devastating consequences, we can only imagine what's going to happen with the implementation of this. So we'll discuss more later, but that's basically it for now.
Excellent, thank you. Heidi, what are the biggest concerns in the rare disease community with the IRA? And there's a specific impact on orphan drugs, Dr. Gottlieb alluded to it, and tell us about that.
Everyone in this room should love the Orphan Drug Act. The Orphan Drug Act is 40 years old this year, and just to set the landscape, Sue, a little bit, before the passage of the Orphan Drug Act 40 years ago, fewer than 40 drugs had been approved to treat rare diseases. So in 1983 and 1984, we had the Orphan Drug Act and some amendments that set the threshold for a rare disease at fewer than 200,000 Americans impacted by that disease. And this law has been tremendously successful. We have seen such a change in the trajectory of the rare disease experience as a result of it. FDA data released last month showed 882 drugs have now been approved to treat rare diseases. We have over 1,150 orphan indications that have been approved to treat rare diseases. Yet there's a tremendous unmet medical need in this space. More than 95% of rare diseases don't have an FDA-approved therapy. So we know in the orphan space that that balance between affordability and innovation has to be very carefully constructed, or else the rare disease patient community will lose out. And to Aaron's point earlier, because 95% of rare diseases don't have an FDA-approved therapy, they heavily rely on symptom management and take a lot of medications to manage those symptoms. And so the impact is felt both on the Orphan Drug Act side and on the non-orphan side. But what Sue is speaking about and what Dr. Gottlieb alluded to earlier is there is a carve-out to the IRA negotiation provisions for orphan products that have one approved designation, which we can get way in the weeds of the Orphan Drug Act when we start talking about designations, and we will get excited. One approved designation, one approved indication. If you have more than one, if you study your disease in more than, your therapy in more than one disease, you become eligible for negotiation. It creates a huge disincentive for that early entry research that is so critical to the rare disease community.
Thank you. Okay, Tom, there are a lot of success stories about FDA-approved drugs being effective for more than one condition. You've worked in the cancer space, and we know many breakthrough cancer drugs have been found to work for additional types of cancer after the FDA first approves it. How is the IRA going to change the frequency of that type of research, and what does that mean for less common types of cancer?
Ooh. Well, first of all, let me say that I didn't have a fight. I talked to my granddaughters over the weekend, and they hadn't seen me with my patch. And one of my granddaughters said, "Are you like that guy on television who gets into fights all the time and crashes?" And I had to stop for a second. Allstate commercials, Allstate insurance. She said, "Are you like him?" And she's young enough that, and I said, "No, I'm still your grandfather." Anyway, I used a teachable moment. I'll just bore you for 30 seconds. I was able to use that opportunity to talk to her about skin cancer and Sun Smart. I like to say Sun Smart, and how I, as a kid, growing up in coastal Central California, was out in the sun all the time, at the beach, wherever. And later in life is when you get hit with some of the worst aspects of skin cancer. So sharing that with the rest of you, if you haven't seen a dermatologist in a while, it's a good idea. I'm not a doctor. I'm not an economist. I tried to figure what's the best way to kind of get into this whole topic. And I thought about from a patient's perspective, because that's what I deal with. I deal with patients. I deal with organizations in our state or nationally that deal with patients. And so I thought of something, this goes back a ways. I thought of something that President Reagan, remember President Reagan? He said, the 9 most terrifying words in the English language are, I'm from the government and I'm here to help. So I'm modifying that to some extent to fit our discussion today by saying, I'm from the government and I'm here to help your prescriptions. And from a patient's perspective, they're saying, okay, the $35 sounds great, the $2,000 sounds great, will I get my medicine? That's the bottom line. Will I get my medicine? And we look at what's happened, and from the Chronic Care Policy Alliance, we were very aggressive last fall, went up on the Hill and talked to legislators and said, okay, you passed, what now? They say, oh, well, that's in the hands of CMS, which is not unusual. You pass legislation and the regulators take over. I was a regulatory attorney for the Federal Communications Commission. Sometimes I knew exactly how I was to come up with a regulation. Sometimes I was free to do what I felt was best. But the reality is, from a patient's perspective, they don't know what's going on. So what we tried to do was approach the CMS with the idea of getting patients involved right then as they started to do implementation. And as you probably know, the June 30 release that they came up and they said, oh, we're going to have listening sessions. We asked for those much earlier. We asked for opportunities to get involved in Section 30, which is the scaling down of the top 10, as I call them. And so getting back to the basic question, what we're hoping for is an opportunity now that the CMS has said, okay, we're going to have listening sessions, that they do it in all 10 areas, that it's open not just to people like us, but individual patients to have an opportunity to ask questions about such things as cancer drugs, and have an opportunity to participate not by invitation, but by being able to sign up or being able to do it virtually. So we'll see what happens with that, because we feel that there was a great opportunity for patient involvement that was totally ignored, and that shouldn't happen. This is too important to the constituents that I deal with, because we deal with access to care issues all the time. I want to give a little explanation of something that you may not be aware of. We had a piece of legislation introduced in Nevada, AB 250. Doesn't mean anything to you, but I think it shows kind of where things could go. There's a national organization that's been pushing this kind of thing, and they came to Nevada and they said, we're going to put together a piece of legislation that ties the state to the federal plan and requires all pharmacists to sell negotiated price drugs at the maximum fair price. And if they don't do that, they're going to be fined. Now, this is state law tied to federal law on something that hadn't been implemented fully. Drugs had not been identified, and prices hadn't been set. And the legislature voted for it. So we were going to have these 10 drugs, and then the subsequent drugs, be available to anyone at the price fixed by the CMS. Luckily, we were able to get a veto. But could that happen elsewhere? Anyway, just a little editorial comment. But as far as cancer drugs are concerned, just real quickly, the concern I would have for the patients is, where are we going with all of this? The use of one drug could be easily targeted for treatment elsewhere. We see this with biomarker testing all the time. And if there is no incentive to develop some of these new drugs, those opportunities just aren't going to be there. And so thinking with my cancer hat on, I see the IRA as being a setback. I know the president misspoke and said we've ended cancer. We have not ended cancer. And it's going to be a long, long time before we ever end cancer because we keep coming up with new ones. And so I hope that we can stabilize the whole situation over time, and especially when we start talking about Part B drugs. That's going to be scary. So that's a long-winded way of saying get involved in the listening sessions that the CMS is talking about offering. And like I say, we've asked for them to do it at all 10 areas. I've got some information on this. If you'd like me to send you copies of what we sent CMS, I'd be happy to do it. So,
Thank you, Tom. That's really helpful. Okay, Dr. Baum, you want to?
Yeah, no, I would just add to that, looking at it from the patient's perspective, which I think is what we always have to do here. So the question about multiple indications for oncology drugs as a reason for research and development to be ongoing from a pharmaceutical standpoint. That applies to cardiology as well. We had diabetes medications that we learned about that were beneficial in heart failure, in kidney disease, and we've expanded indications there. But the heart of the matter here, I just want to get back to for a second, is that there are, because this is so complex, there are a couple of things we know about IRA. What do we know? We know the patients are going to be limited ultimately to $2,000 out of pocket. So that, in a way, is a sop to Cerberus. It's a sort of it starts a shell game where patients go, oh, this is wonderful. We know that drug prices are going to be reduced for pharmaceutical companies, and that patients look at and go, oh, that's wonderful, because pharmaceutical companies have always been vilified. It's easy to do that. But the real problem is that we also know that innovation will go down. It's already happened. Dr. Gottlieb said it. I've spoken to heads of pharmaceutical companies. They have told me that in the space, in cardiovascular space, a terrifying reality, as I was told by the president of Novartis, that their Lp(a) program would never have taken place had he known about the IRA. That will be, just for those of you who don't know, probably the most important cardiovascular innovation in a matter of for 3 decades probably, and reduce the risk of heart attack and stroke. So we know all these things, and the bottom line to me is that that patients are making a Faustian decision, or by if they don't recognize what's going on, by saying, yes, this is great, we only have to pay $2,000, but downstream, they're not going to have the cancer drugs, they're not going to have the cardiovascular drugs. They'll be left with multiple morbidities and mortality as a consequence. So just to frame it in that light.
Thank you. And I know, so you talked about the follow-on for cardiovascular drugs. Heidi, can you talk about for rare disease?
Absolutely. I think that a lot of us in this room have talked about drug repurposing and the idea of taking a product that's already been proven to be safe and effective and exploring whether or not it may work for another disease state. And I think that in the rare space, as I said, 95% of the more than 7,000 known rare diseases don't have an FDA-approved therapy. Drug repurposing is a beacon of hope for those in our community. So when you have the IRA's exclusion being so narrowly tailored, really disincentivizes companies to do that drug repurposing and do that initial research. Talked about designations earlier. A designation is a key component of the Orphan Drug Act. It's a critical tool that the FDA offers to companies that are developing a therapy that unlocks some of those incentives that have been so successful in driving innovation in the rare disease space. Securing a designation unlocks tax credits, it unlocks research funding, it allows you to waive your PDUFA fees, critical things for especially small biotechs who are exploring this space. if you have more than one designation and you're studying a bunch of different rare diseases, that's a win from the patient perspective, because even if that fails, you know that therapy doesn't work for that disease. That disease state can move on to the next potential therapy. So tried and failed is also a win for our community. Tried and success is a bigger win for our community. But we want to see those incentives that the Orphan Drug Act unlocked and established 40 years ago be enough to continue to drive innovation. And we are concerned that the IRA, because that orphan drug exclusion is so narrowly tailored, will disincentivize repurposing, which has been an administration priority, but it'll disincentivize label expansion into other disease states where therapy has been proven to be safe and effective in one place. And I think that it is really important that these decisions are being made now. And therefore, the time is now to address some of these shortcomings that we see that have been pretty clearly defined now by the CMS guidance. And as Tom said, NORD's been active on this. We've met with CMS a lot of times. I am confident that they do know the difference between a designation and an indication. They do know that. But they have ruled that, as far as they're concerned, the statute is very clear that they can have only this very limited exemption. It's on us now as advocates to try to address this in the halls of Congress.
If I may just, excuse me, provide a little color commentary on it. So I'm from the Diabetes Patient Advocacy Coalition. You all are so very smart. I mentioned to somebody earlier today, there's always like the dumbest person on the panel, and I think it's me today. But as a person who's lived with type 1 diabetes for 36 years, and I was diagnosed in 1986, some of you have heard this story. At the time, the insulin that everyone used was a derivative of beef and pork insulin. They had made Humulin as well, which was relatively new when I was diagnosed. It took 2 minutes to get a blood sugar reading, a blood glucose reading. Now I have a Dexcom that tells me like every second. You've probably heard me beeping. At the time, you took your insulin based on roughly like your age and your height and your weight, and you ate according to the insulin that you took. So the American Dietetic Association, which it was called at that time, had an exchange diet. Food labels had how many exchanges of each type of food were on there. 1 can of shelf-stable brown gravy was 2 vegetables. Allow me to repeat that my mother fed me gravy as a vegetable. In short, we have come a long way. We have come an incredibly long way from gravy as a vegetable and so many innovations before then. To that point, I, as a person who lives with diabetes, cannot ask for provisions that make insulin untenable, because without it, I'm a goner. And then somebody else is going to be the dumbest person on the panel. So.
I want to talk a bit, I know you all have mentioned now about the impacts on innovation. We're going to have a whole panel on that in the second panel. But I think that to get back to what patients care about, they really want to know, am I still going to be able to get access to my current medications, to future medications? And, you know, there have been previous iterations of direct negotiation, which is really price setting, in the form of international reference pricing and most favored nation. And in previous Congressional Budget Office estimations, for direct negotiation to work properly, you have to have a reduction in utilization, right? You just have to cut access, and it can be as much as 26% in one of the reports showed, and that was considered a conservative estimate. So what are you all worried about with regard to access with price setting?
I can respond because we hear from patients. You know, one of the things that, and I preached about the listening sessions, most patients that I deal with from an advocacy standpoint, they don't understand this. They really don't. All they want is their medicine, okay? And they advocate to keep that. But one of the concerns I have is, in that respect, is there's another side to this that we haven't talked about, and that's utilization management. That patient is stuck between, on one side, utilization management, prior auth, step therapy, and on the other side, IRA, okay? So what happens if the health plan decides they don't want to put on their formulary these negotiated drugs? Is there any requirement that they do? No. IRA doesn't deal with this. They didn't deal with the health plans. And so what's going to happen? Well, it's going to take organizations such as represented here and others to take charge.
Yeah, so I would say even if they do have to have one or two of these drugs on their formularies, there's still utilization management techniques that can be utilized very effectively. So I'll give you an example. In 2015, the PCSK9 inhibitors were approved by FDA. They're two drugs that were I think the greatest innovation in lipid lowering in 3 decades. I had teed up about 100 of my patients with a disorder, familial hypercholesterolemia, to be put on these drugs. And what's that, a rare disease? Well, the HoFH is a rare disease. And to a person, everyone was denied. Okay, so what happened was ICER, evil ICER, and they are actually genuinely evil. Evil ICER had already, set the stage for PCSK9 inhibitors to bankrupt the system. And as a consequence, payers put all sorts of utilization management systems in place, prior auths, that were just totally obstructive. Anyway, now 8 years later, and after a 60% decline in the price of the drugs, which was at the time guaranteed to make access to these drugs better, which it never did, there's still somewhere between 5 and down to maybe 1%, depending upon what you read, of eligible patients who have been prescribed these drugs. And I published with other individuals an article in Circulation demonstrating that the prior authorization procedures that were utilized to block PCSK9 inhibitor uptake, block access by patients, led to a large number of heart attacks and strokes and cardiovascular death. And the same thing is going to happen here. There's just no doubt in my mind the same thing is going to happen here. So it's all about the utilization management post 2024 or in 2024.
Well, and I think in the rare disease space, we know that access is a really challenging issue because the reality is a lot of our patients can't afford their drugs. That is just the truth. A $2,000 out-of-pocket cap is going to incredibly benefit the rare disease community. Specialty tiers with their 40 and 50% coinsurance make accessing an FDA-approved therapy for those that are lucky enough to have them oftentimes very challenging in the rare space. And then you add on the layers of utilization management. For us, a huge victory is getting FDA-approved therapy, but on top of that, the patient access challenges, whether they can afford it or their insurance will cover it, poses a whole nother set of challenges that are really, really difficult for our community to overcome. Because 95% of us don't have an FDA-approved therapy, a lot of symptom management means they're not fighting 1 or 2 prior authorization requests or denials. They're fighting multiple ones at multiple times on multiple fronts. And so I think this is something we're really closely watching. Yes, the IRA requires all negotiated products to be placed on a formulary, which is good. But we do want to see preferred formulary status for some of these therapies because whether you agree with it or not, at that point in time, CMS will have deemed it to be a fairly priced therapy, and therefore patients should have access to that fairly priced therapy from the NORD perspective.
A lot of the conditions that you all are mentioning impact communities of color. CMS puts out that one of its priorities is health equity. It's, in fact, one of their strategic pillars. But another strategic pillar is also preservation of the Medicare trust fund of the program. So what do you think the impact of direct negotiation is going to be on underserved communities, like rural communities, lower income communities of color, in diabetes, in cardiovascular diseases, and in rare diseases, and cancer too, all of you?
The underserved communities are always impacted the worst, and no matter what the policy is going to be, right? So I think it's fair to say that it's not going to be good. Okay, that's pretty self-evident. But what I don't think people are focusing on or paying attention to, and I think you'll like this given what you do, it relates to ageism. Who is this going to impact first? It's impacting Medicare population, and as I inch very closely to that, incredibly closely, I on a personal note, I'm also disturbed by that. But here Medicare patients have paid hundreds of thousands of dollars into the system over, a lifetime, get to the system, and what do they get? Well, they get fewer drug options and less access to those drugs. So, from an equity standpoint, if you look at just that, the elderly are being severely disadvantaged.
In the rare space, the majority, more than 50% of those affected by a rare disease are children. But the hope for everyone in this community is that they will age into the Medicare system, that this is something that they will, from a life expectancy, move from, 10, 20 years to 65, 70 years. And that's how the lens with which NORD is looking at this. We're looking at the overall systematic impacts of the IRA to patient access. And will patients be able to see a new therapy for their condition, a better therapy for their condition? Will they be able to afford that therapy? And will they be able to access that therapy ultimately? And I think that that is a real challenge in this space. We know that the rare ecosystem is extremely sensitive. Any disincentives that exist will result in fewer therapies being developed. And we know the success of the Orphan Drug Act has driven tremendous investments in the rare disease space. We don't want to see all that success for 40 years be disincentivized or not being enough of an encouragement to continue to study those therapies.
It's no secret that communities of color and low-income communities are disparately impacted by diabetes. Anytime that the scope of options are narrowed, it's harmful for patients. Additionally, $2,000 is still a lot of money. We are very fortunate to be able to say we're so grateful for a $2,000 cap. You put a $2,000 bill in front of a significant number of Americans, and that's enough to turn them away at the pharmacy counter, regardless of what their options are. That is of tremendous concern to the diabetes community.
I think that's part of why the smoothing component to this is also so critical, because yes, that $2,000 bill on January 1st is too much of a hurdle for many patients to overcome. The ability to smooth that out over the course of a year is really critical. It's unfortunate that's an opt-in. We have, as a community, a lot of education that needs to be done around that, so patients aren't facing that huge bill that first of the month. That is something that the IRA does address, and I think it's something that NORD's fought for a long time, and we're pleased to see included in it.
And not knowing the tiers that some of the medication is going to wind up with gets back to, is there going to be zero copay? Is there going to be a low copay? How's that going to look? And we don't know, and that's going to, I think, significantly impact people of color, people of low income. In Nevada, we have another issue, and that's cultural competency. We're a minority-majority state now, and we have that issue of doctor-patient communications, which certainly become an important part of any discussion about treatment. So it's a very complex situation.
Yeah. Tom, you bring up a really interesting issue, which is really like the interference clause, which is the very first language that's in the Medicare legislation, where the program is not supposed to insert themselves between patients and doctors or clinicians. Talk a little bit about that in the context of the IRA.
Can you be a little bit more specific on that? I'm trying to get a handle on what's the best way to answer that.
Sure. So if Medicare as a federal program, as part of its original creation and statute, is Congress basically added in language in part to make sure that they were saying this wouldn't become socialized medicine for the whole country. And then in part to put a line that Medicare, which is essentially a federal payer, would not be dictating clinical care, so that there needed to be a line. Now, I think a lot of people would argue that a lot of policies in the Medicare program today do dictate clinical care, and that we're sort of moving more and more in that direction each day. So I'm just wondering, from your perspective, it doesn't have to be you, anybody else in the panel, from your perspectives, how is this sort of, deciding around direct negotiation, which drugs will be on, which drugs not, these issues of utilization management, all of these different provisions, sort of picking and choosing different drug areas. How does that sort of get in the way?
Well, it goes back to something I said earlier, and that is in the whole process of implementation, and that was our concern from day one. That's why we talked to legislators and asked them to write letters to CMS, is that input from patient groups, from patients, about such issue as clinical care and how all this is going to impact, just wasn't, it wasn't part of the process. So how do we change that? Can we change that? Because the bottom line is the patient. And this, I'm speaking for myself now, not for Partnership to Fight Chronic Disease. I don't view healthcare as a commodity. I don't view prescriptions as a commodity, yet we treat it like pork bellies. And I think that's a big, big problem in this country, is to keep in mind that we're dealing with people's lives and quality of life.
Yeah, so I would just add that, I've always advocated for the sanctity of the doctor-patient rule. Is this on?
It is.
Very strange. The sanctity and the primacy of the doctor-patient relationship. And in going back to 2015, when the PCSK9 inhibitors came out, and all of a sudden we as cardiologists realized there's another person in that room blocking what we want to do for our patients. It was actually the first time I had ever experienced it, and our community of physicians had experienced this. A lot of other fields had, but we had never dealt with prior auths. There clearly is always someone else in the room now dictating how we can manage our patients. And from a commodity standpoint, physicians have become commoditized, right? So we're no longer called doctors, we're called providers. What is a healthcare provider? Well, the MA is a healthcare provider, so there are many tiers of healthcare providers. So we have been commoditized, the whole system has been commoditized, and the utilization management practices that have been implemented over the last couple of decades and will be again on steroids, I presume, with IRA, are going to actually absolutely devastate the doctor-patient relationship.
To punctuate that, one of the greatest American tragedies is that patients have been kept from the center of healthcare. Not just the center, but many of the surrounding layers. And Tom mentioned earlier that you hope that actual patients, not just a select few, are brought into the conversation. It's our responsibility as patient advocates to encourage patients to do so, but we also have a responsibility as those working with legislators to really push for that access.
Yeah. I want to open it up for audience questions, but before I do, I just want to say, Tom, and if you end up getting your wish and there are regional meetings with CMS, or for that matter, anybody else, any of the other groups in here that are meeting with CMS, they're very defensive about that provision that I mentioned and said, we don't dictate clinical care. We're not telling doctors what to do. So when you go to them and say, that's what our experience is, that definitely is a challenge. So I just would encourage advocacy organizations and grassroots to bring up that challenge, because they are increasingly, in our view, going over that line. And that needs to be called to Congress's attention, to the administration's attention, and it needs to be turned around. Any questions?
I never ask questions at these things, so. My name's Sherry Hicks. I'm here with Genoa Healthcare Pharmacy. So I'm in the pharmacy space and have experience with prior auths. With these meds that are going to be limited, if, like the Eliquis example, if somebody is already on Eliquis and maybe they failed warfarin 10 years ago, so that doesn't really count, but they've been on this for 4 years, will a step therapy be required, or will a prior auth be able to kind of grandfather them in, for lack of a better word.
So this is part of the problem with the IRA. I don't think we know answers to these questions, and that's the terrifying aspect of things. And the way I'm looking at this is I view this through the antithesis of rose-colored glasses. I envision that the worst-case scenario is always going to appear, and as we saw with what was attempted with the Eliquis non-medical switch. I think the same sort of thing can happen over and over again here, and I would predict that it will happen because the whole idea here is to reduce cost, to shift money from Medicare to other places. But who's going to carry the burden? It's going to be the payers, and how are they going to recoup their money? They're going to take it out on the patients, and so that's what's going to happen.
Any other questions? All right, I'll ask a final question of the panelists. From your perspective, tell me one thing that you would like legislators to know about the impact of the IRA and in regards to this, list issue and all of that, and then what you would want other patients to know. So those two things. Start first.
Ooh. One thing we would like legislators to know is that there is not one answer to any of these conditions that we work with. There is not one solution, there is not one prescription, there is not one drug, there is not one therapy. Being able to say that you addressed diabetes, a rare disease, a heart condition, does not solve diabetes, rare disease, or heart conditions. What we would like patients to know, or something that we would encourage patients, is really to understand the layers of the pricing system. And I believe Seth mentioned it earlier, that manufacturers get vilified. But I said that we can't make insulin untenable. We can't make any of these drugs untenable. We need to continue investing in the innovation and the advancement of care. And so I would encourage patients to better understand the system and how they're impacted.
Excellent, thank you.
For legislators, I was a Hill staffer during the Affordable Care Act, so my hope is that this isn't the Affordable Care Act 2.0, where there was absolutely no willingness to address fundamental problems. It was an all or nothing bargain. And I think we know that there are some problems with legislation that's written very quickly, very fast, and passed very quickly. And so things like the limited orphan drug exclusion, I think, is something that there probably can be a lot of bipartisan support to address. And we need to be willing to, I hope that they will be willing to tinker around the edges with this as we start to get more data and we start to understand the impacts and be willing to address those challenges, big and small, with the legislation so we get this right, so that ultimately patients do have that impact. For patients, I think understanding that this is a really nuanced and complicated space, and that's something that the rare community really does understand. So many in the rare space don't have a therapy. They're holding out hope. They understand the value of innovation. And for those that do have a therapy, they're holding out hope for better therapies and being able to more easily access their therapies. I'm going to add to your question, Sue, though. For CMS, I hope they understand they have an opportunity to signal what value is in this context by rewarding companies that innovate and produce better, more effective therapies for their communities, that they will be rewarded if that product is selected for negotiation. We have an MFP associated with the law, but whatever CMS can do to show that that value will be rewarded within this negotiation process, they have a really important opportunity to do so within this context and this list that's going to be coming out. So there you go.
Thank you. Tom and Dr. Baum, I'm just going to challenge you to 30 seconds each.
30 seconds each. Legislators, talk to them about changes that may be necessary. That's always available. To somehow legislators forget that. From a patient's perspective, they're not going to understand until this gets sorted out. And so I think we need to be prepared once pieces come together, the listening sessions are over, try to educate them on how best to protect themselves.
30 seconds. Okay, so I would say to the legislators that we could solve the problem of patient out-of-pocket costs by rescinding the anti-kickback statute from 1972 and allowing coupons to be used in the Medicare population. We could also deal with the drug prices, which are not increasing, but we could significantly reduce them by eliminating the PBMs. So we could handle both of those issues just like that. From the patient standpoint, I would say don't make the bad deal, the Faustian deal. Yes, it's great and needed, the $2,000 out-of-pocket limit. But what you're sacrificing is future innovation, access to drugs you don't even know about. You don't know about the disease you're going to have in 10 years. That's all going away, and I would just be careful and vocal.
All right. Please join me in thanking this great panel.
We're going to move right into panel 2. I'm Candace DeMatteis. I'm the Policy Director for the Partnership to Fight Chronic Disease, and it's my pleasure to introduce our moderator for panel 2. Debbie Witchey is the Executive Vice President and Chief Operating Officer of the Healthcare Leadership Council, where she advocates for all sectors of the healthcare industry on topics such as access and coverage, population health, and Medicare. So you can see why we asked her to be the moderator. She also directs HLC's government affairs and grassroots operations, including 6 regional field directors covering all 50 states, coordinating 200 in-district meetings and events with members of Congress annually. She also successfully advocated for passage of the CARES Act, H.R. 6 opioid legislation, the Bipartisan Budget Act that repealed the Independent Payment Advisory Board, the Creating High-Quality Results and Outcomes to Improve Chronic Cares Act, and the Medicare Modernization Act. So please join me in welcoming Debbie Witchey and our second panel.
Like, where is everyone? Right. Well, thanks, Candace. I'm going to introduce our esteemed panel, and I'll start with Kirsten Axelson here to my left. She's with DLA Piper. She focuses on biopharma reimbursement and health policy. She's worked in the biopharmaceutical field for over 20 years, and I realized in reading these introductions, we have a lot of over 20 years. She helps her clients work on business strategy and also focuses on public affairs. In the past, she's worked in the U.S., EU, China, and emerging markets. And she is an economist and focuses on Medicare reimbursement, payer contract negotiations, and most interesting to me is designing innovative reimbursement contracts. Next to her, we have Ipsita Smolinski. She's a veteran advisor on healthcare regulatory and legislative issues, also with over 20 years experience in healthcare policy and economic analysis. As managing director of Capitol Street, she advises clients on key trends and major actions coming out of Washington, D.C., as well as the state, court, and also stakeholder levels. Next to her, we have Peter Rubin from No Patient Left Behind. He also has more than 20 years experience in health policy, strategic advocacy, and public affairs experience. Peter has held senior level positions spanning public and private sector payers, innovators, and also regulators. He ran the United Healthcare's Medicare business. He was also in the past led Aetna's federal government affairs team during implementation of the Affordable Care Act, and his government experience includes majority staff director at the HELP Committee. And then last but not least, we have Ken Thorpe, who I think mentioned earlier this morning. He's the chair of the Partnership to Fight Chronic Disease, also the Robert W. Woodruff professor and chair of the Department of Health Policy and Management at the Rollins College of Public Health at Emory, and he served as President Clinton's Deputy Assistant Secretary for Health Policy during the Clinton administration. So welcome to the panel, and we'll get right into discussion, and I think we've heard a little bit about this both from Dr. Gottlieb and the previous panel, but one of the, I think sometimes and particularly from people who don't really follow health policy, they've said to me, well, this doesn't seem like that big of a deal. It's just 10 drugs to start. And it's sort of like just working around the edges. But I think all of us in this room know that even small policy changes can have a ripple effect and significant impact on the ecosystem down the line. So Ipsita, maybe we can start with you and then others can chime in. What are some of the unintended consequences? I think we've heard some of them today. And also thinking about the short and long term, and what do you think will be the impact? Yours is not on.
There we go.
Yes.
Yes? Okay.
Yes.
And thank you for pronouncing my name right, because I have a very Indian first name and a very Polish last
I
name.
practiced.
So that's a rare one. And again, just like for perspective, our bailiwick is really, healthcare policy, but kind of translating that into the industry impact and ripple effects. So I'm happy to kick off. I guess as far as the top 10, we have a running chart. I mean, I can mention 2 or 3 and then let my fellow panelists chime in. But, we have a chart that we've compiled of all of the companies that have actually said, look, we're going to abandon a phase 1 trial of X, or we're going to, instead of perhaps going into ovarian cancer, we're going to go into a bigger indication like prostate cancer first. These are companies like Eli Lilly, cancer drugs, cardiovascular drugs. So certainly since about last October or November, we've heard companies starting to ring that bell that because of the IRA, they're going to be abandoning projects, clinical trials. Again, repurposing, going for a bigger indication first. I think another ripple effect in the industry, at least from the capital markets perspective, is that you have companies that, who are perhaps trying to partner, joint venture, perhaps do a deal. If there's anything in the pipeline that has an IRA exposure, then typically that deal might be abandoned. And actually, the Roche CEO made comments on his earnings call just last week, saying exactly this. As we look at strategic acquisitions and such, if there's any impact with regards to IRA, then we're going to walk away from it. So those are a few. We heard also on the last panel about prior auth and utilization management. That, of course, will happen with the Part D restructuring, given the higher, kind of liabilities in the initial and catastrophic phases.
Others want to share perspectives on unintended consequences?
I'll just add a couple, and I think our keynote speaker, Scott Gottlieb, raised the potential for drugs to be launched outside of the U.S. I'll also add to that this law really encourages the most inefficient type of R&D. Microphone. This law really encourages the most inefficient type of R&D because they do pursue the biggest drugs. They only carve out drugs for one indication. Many of us have criticized the estimate of how many fewer drugs will be developed as a result of this law. I actually think what will happen is smaller drugs will be developed as a result of this law, and smaller drugs tend to be expensive drugs. It doesn't allow us to capitalize on existing innovation and develop the next follow-on treatment, which I think we talked about Me Too therapies earlier this morning. Me Too therapies are great for competition. This is pushing us towards an environment where there's going to be less competition and more attempts at going into smaller markets that won't be affected as much by the Inflation Reduction Act. So I think that's, unfortunately, this act is really moving us into a direction of less efficiency and higher prices.
Yeah. I mean, I think that's an excellent point. When you think about how much research has been done in post-market introduction and drugs that have been introduced for one indication, and then through that research that happens post-market, discoveries are made. And I think we would all agree that the incentives to do that post-market research are not there because those drugs will move into the list, so to speak. So moving on, one of the big appeals of this program when when they were trying to get it passed was this idea that there was going to be savings for Medicare beneficiaries. And at the end of the day, I think we all agree it should be about the beneficiary at the heart of it. So Peter, maybe you want to kick off. Do you think we'll actually see savings for Medicare beneficiaries, and who really is benefiting from the IRA?
Absolutely, and thank you. As No Patient Left Behind, which we are a coalition of investors, innovators, and patient advocates, we think about the unintended consequences of IRA in terms of an impact on patients as, one, the lack of truly meaningful insurance reform, either in the bill's passage or in the implementation that CMS has indicated. So it's a great thing that they capped the out-of-pocket costs at $2,000 per year, which will help at least 1 million beneficiaries to start. It's a great thing that they did the smoothing. It's a great thing that they did the $35 insulin cap. However, in implementation, CMS is saying, hey, even if we set the price of this drug, we're not going to require the insurer to put that on the lowest formulary tier. So there's still no guarantee that the beneficiary will benefit from the government negotiation versus the plan. Obviously, we would have liked to see the cap be lower. But the other consequences you're going to see, which are more unintended, is really going to be around this sort of fewer new small molecules for diseases of the aging. Over the last 3 years, half the cancer drugs approved by the FDA were small molecules. So you're basically taking away that incentive that's going to harm patients. You're going to see more shots than pills. So when you talk about large biologics, those really are sort of shots that are physician administered under Medicare, for which the bill did not cap Part B out-of-pocket costs. In fact, and once again, they don't guarantee that the savings from the government negotiation or even the inflation rebates will be passed on through the Medicare Part Advantage plans. And then lastly, I just want to plant the seed on the sort of role that ICER is going to play in terms of determining which drugs you can get access to and which drugs are worth it. And you're going to see in the fall them release this big report about how to negotiate for CMS. And you just need to keep in mind, a lot of work that we do is to illustrate that ICER uses faulty math that basically undervalues the patient and societal benefits of innovation. And so those are really the 4 ways that patients are really not going to see the true benefits and opportunities of a sort of a better bill.
Thanks, Ken.
Yeah, I was just going to add that I think it's probably important to sort of look at the whole components of this act. So the piece on patients is great in terms of out-of-pocket caps. Didn't go far enough. I would have been troubled somewhat that in the Medicare Advantage program, the CMS gives the health plans the flexibility to eliminate or reduce cost sharing for 8 major chronic health care conditions, and it's been very, very effective. I mean, they still come in at 11% below fee-for-service. The rate of growth in MA is less than fee-for-service per capita. It just seems puzzling that you have half the population that's really paying 0 or no copays for 8 of the most important chronic conditions, and in fee-for-service, we capped insulin, which is super, but they're still paying $2,000 out of pocket. I mean, the rest of the act you can almost just throw out. I mean, there's obviously, in part, a budgetary exercise to generate Medicare savings. Nothing really changed in terms of the system. You're just basically having a heavy hand come down on prices. But the dynamics of how the system works with PBMs in the middle, really nothing has changed. And that's a shame. I think what would have been more useful is to have a broader policy discussion that says, well, yeah, we see that list prices are growing at a fairly rapid rate. Why? What's going on here? What are the policy options on the table that can solve the underlying problems and the underlying issues? We didn't have that debate. Rather, we came in and just simply said, well, we're just going to do price regulation, and that's the end of it. Well, I mean, those underlying dynamics haven't changed. There's nothing in the system that's changed. We could have had a more thoughtful discussion about really making reforms. This isn't reform. I mean, this is just simple price regulation. What would reform look like? And we just haven't had that discussion yet, and that's something that I think that we need to have. I'm glad to see Congress and the Finance Committee and others are looking at PBMs, and that they're looking at the broader system right now. And some proposals coming out last week, and that's encouraging. But we really need to have that broader policy debate on what's going on. I'll just end with an anecdote that everybody knows on the insulin side. We know that list prices for insulin have gone up rapidly. I mean, we understand the underlying incentives why they've gone up rapidly. Bigger list prices, bigger rebates, better formulary placement. But if you look at that market over the last 5 years, the amount of money going to drug manufacturers has gone down by 40%. The money's not going to the manufacturers. It's going to other parts of the system, largely PBMs, in part pharmacies, and the health plans. So again, unless we take a holistic view of this system, we just continue to miss the boat on really making structural fundamental changes that need to be changed in the drug pricing system.
Yeah, and I think too, even though some of the committees are looking at PBM reform, they're looking at it maybe not in that thoughtful way that you're suggesting. So we're going down a road that still is not going to solve a problem. So it's troubling for sure. Others have thoughts on? Ken, anything you want to talk about related to access restrictions and what that might look like?
Yeah, it's sort of interesting that we're stuck in a world of health insurance benefit designs from the 1960s. Fundamentally, it hasn't changed much in terms of structures of deductibles, copays, prior auth, and so on. And it just sort of runs in complete contrast to where science is going. With the Genome Project and our ability to do pharmacogenomics. The problem with the access restriction side is that there's a view that there's an average patient. And we know there's not an average patient. People respond very differently to different medications, and we have the scientific ability increasingly to predict how different patients are going to respond. So to sort of have a system that is sort of, whether it's step therapy, which is take drugs until if you fail, then you get to move on to the next one. If that fails, move on to the next one. Well, we have the ability for a lot of things that says right from the very get-go, we can predict how that patient's going to respond to the most effective medication. So I think the whole concept of it doesn't make any sense. And again, I think it goes back to just this tension between where science is driving us and sort of the 1965 health insurance benefit design that was designed for patients that weren't chronically ill. They were designed for patients that are acutely ill, that had acute episodes, and obviously that's not the patient of today. So unless I think we rethink the design of health insurance benefits, and I think give MA credit, they've done some of that. They've given plans flexibility to bring in social determinants and food and other things as part of the rebates. But we need to fundamentally rethink the design of these benefits because the 1965 benefit world doesn't work today.
Yeah, good point. So we've heard a lot about the topic of the impact on innovation and what it's going to mean, but Kirsten, maybe you could talk a little bit more about what it really means for small companies in particular, and more broadly.
Yeah. I mean, I think whether well-intended or well-intended to be politically appeasing, there's elements of the IRA that were intended, I think, to say, oh, it's okay, real innovation is going to be spared, right? There's a small company exception that sunsets. But the fact is, small companies survive by developing an asset and then a big company buys them. And so right now when a big company buys a small company, they will do that if they believe there's cost efficiencies to be gained. They're going to make more than they spent purchasing the small company. But now that small company asset, if it becomes part of a big company and that big company is able to nurture that and create a big drug, well, then it's subject to the inflation penalty. So I guess the larger point I want to make is no drug is exempt from the impact of the IRA. We talked this morning about rare diseases. They are not exempted. Small companies are not exempted. A drug that is not on the list is not exempted because now they are competing against a drug that has government price controls. So we have to assume that every single drug is affected by this. And then, global health is affected by this. 40% of drug revenue comes from the U.S. The rest, and so the drugs are developed if they can be successful in the U.S. market. Yes, we may see companies launching outside of the U.S. first, but it's not like we can make it up by selling more drugs in other countries. That is a model that has not been shown to work. And in fact, 50% of all oncology drugs, the revenue is derived from the U.S. So, for diseases of the elderly, where Medicare goes global health, and this law affects all drugs for the elderly. So as we think about ways to mitigate the impact of this law, I think we need to be focusing on the most deleterious effects, the things that most affect incentives to innovate in the lowest cost, most effective drugs. And I think we've talked about a few of them, this penalty for small molecule innovation, the penalty for more than one rare disease indication. You see in guidance and implementation, CMS has been just expanding, putting two drugs of the same moiety together as though they were the same drug when in fact they may have had different clinical development programs. So whether it's through changes in the law or changes in implementation, we need to be thinking about how can we undo some of these provisions that really are going to have the biggest impact on what kinds of drugs are invested in for diseases of the elderly.
Anyone else have anything they want to add on the impact to research and development? Peter?
Just to add, we talk to small company, development stage companies quite frequently, and we have a CEO from a company that's working on cancer who has cancer who says, I've got to stop doing research in small molecule R&D. We have small companies that talk to investors and have polled them and who found that 6 out of 7 investors no longer want to invest in companies working on small molecules or get asked, hey, can you take this medicine and rather than do it as a small molecule, make it as a large molecule. And obviously downstream effects are higher cost for society when that happens. So it's a big deal what's happening, and so all this new small molecule R&D is really going to be stopping for diseases of the aging. We see it quite frequently. And then lastly, the downstream effects of that are if there's a disease that primarily impacts older Americans, like colorectal cancer, you're going to see less innovation for that, even though it impacts an increasingly significant amount of younger Americans. And so these unintended consequences are easily fixed, quite frankly, where you just say, hey, let's lift the small molecule and have parity at 13 years for both small and large molecules together. Those are types of things that you could do to basically stop this from having a lasting long-term negative impact on patients.
I would just chime in by saying that I think for 2026, it's 10 drugs, right? And Part D is in David, and then 15. I think 2026, we all kind of know what that list looks like. 27, 28, when Part B is in the fold, I think becomes a lot more concerning for investment for companies. And there's always this. I actually don't think the 9 and 13 parity will end up being 13. I think there's some legislators that are looking at parity as, well, how about 9? Or, maybe you meet in the middle at 11, but
I agree.
There's a budgetary impact to doing so. And right now with the significant savings, I think Ken mentioned it, it's kind of like a budgetary, savings mechanism versus true reform. But, you could see members of Congress thinking of it as a bit of a piggy bank, like, hey, well, and I think there was a bill just introduced maybe in the last week to expand that list from 10, 15, 20 to more, and I think that's only going to be more alluring in an era where we've spent about $7 trillion with a T on COVID. We've got to get our fiscal house in order. Why not just add more drugs to the list? Could be the very simplistic view.
Yeah, I think that's an excellent. I think that what the president's budget proposed dropping the number down to something like 5. I think so. I think you're spot on that there's this movement to just keep lowering it, not to increase anything to 13. I also, when I think about the issue, I try to relate it back to the personal experience so that I have stories to tell when I'm talking to stakeholders and policymakers. And I think all of us have friends probably who are undergoing cancer treatment, and not all treatments last forever. And something may be working great, and then it isn't anymore. And having the opportunity for multiple options and multiple therapies really is what's keeping people alive until the next innovation comes along. And if we don't have that anymore, then people are facing some pretty dire consequences.
Yeah, let me just add to this on sort of, to me, again, going back to this policy framework of how incredibly myopic this piece of legislation is. Really what we should be focusing on is per capita spending, not silos of spending. And the irony here is that on the prescription drug side, we know that if you, for example, increase out-of-pocket payments and costs to a patient with 4 or 5 chronic conditions by $1, it increases total spending by $1.80. So the silo mentality makes no sense in terms of what we're doing, point one. Point two is, if we're really interested in healthcare costs and premiums and what patients pay, why the focus on drugs? Hospital costs per day are double here what they are in Europe. Outpatient surgical procedures are double. Ambulatory care procedures are double. Everything's double. I mean, we know that if you look at U.S. versus Canada or the United Kingdom, healthcare is more expensive here. That's, again, a discussion we haven't had, is sort of how can we reduce the rate of growth, make the system more efficient, provide better outcomes for patients holistically, rather than coming in and beating down on one sector, where that's the primary tool we have to control spending by managing chronic disease, to make sure the patients are adherent, to keep them out of the hospital, keep them out of emergency rooms and clinics. So I just think it's not only myopic, but somewhat ironic, the sort of sector-specific focus here, when we're really missing the larger boat on, let's really look at reforming the healthcare system in a way that makes it more responsive, more efficient, and provide better outcomes. And we've gone in the exact, as we're hearing from these two panels, we've gone in exactly the opposite direction. We're going to make things worse rather than better. And to Ipsida's point, I mean, let's be honest. This was a budget exercise. This is a way for Medicare to save money, to spend elsewhere on other priorities and initiatives, which I think were largely good ones. There are a lot more effective ways to save money in the Medicare program rather than doing what we just did with the Inflation Reduction Act.
Yeah, excellent point.
Could I add a follow-on point to that? And it's not a pipe dream. Ken mentioned earlier that costs are lower in Medicare Advantage. There's been a movement, more people going into Medicare Advantage prescription drug plans, more low-income subsidy-eligible people going into Medicare Advantage prescription drug plans. Those plans focusing, there's plans that have 90%, 70% dual eligibles in them. They're clearly finding that they could manage those people and their complex diseases and be successful. Well, so what have we done with the IRA? First of all, nowhere in the IRA is the term quality used, although I think I might quote Sue. I think other than quality adjusted life years will not be used. Right, so we moved away from quality. There's nothing to encourage that continued movement over to MAPD, where you could have actually seen that type of holistic care management and cost reduction. And so as this law is implemented, I think a couple things we want to remember. Not only is there not an emphasis on value, by reducing the subsidy in the catastrophic and also for low-income subsidy eligible people, we have made very ill low-income people more expensive and less profitable to the plans. So those of us who are in advocacy really need to think about, how do we get that monitoring of the coverage? Because as we saw in the Affordable Care Act, the plans excluded the drugs from the patients that were the most poorly risk-adjusted, people with MS, people with rheumatoid arthritis, where the natural reaction is going to be to clamp down on the access to those drugs that are no longer profitable. And in particular, while I think the out-of-pocket cap is great, an out-of-pocket cap with no complementary formulary oversight is going to be a disaster for patients. They're just going to find other ways other than cost barriers to keep patients from getting those medicines. And none of that is right now contemplated. CMS is saying they'll monitor to make sure that the price-controlled drugs are on formulary. Well, we've seen how the monitoring of access for the 6 protected classes has gone. There's still plenty of step edits, utilization management, people abandoning their prescriptions. So what do we do going forward now that we are in the place we're in to make sure that we don't see these people, in particular low-income subsidy eligible and people taking specialty drugs, not getting access to their medicines?
Yeah, excellent point. It really, instead of looking at care coordination and outcomes and how to deliver better care, we're just, as Ipsida said, we're really just looking at a budget exercise. So we've been
I
talking.
think also, I
Oh,
just
go
would
ahead.
love to follow up on
Sure.
what Ken was saying. Congress has a tendency, I think, if you've been observing Congress as long as we have, although I'm young, that, it was drugs last year, right, with IRA. Now there is a look under the hood at hospitals with some of the site-neutral issues and, PBMs. So I think that, there's always kind of like, all right, let's really do away with high drug prices, we can take our victory lap with the IRA. But I think there is more systemic reforms being envisioned. Not saying that they're going to happen overnight, but particularly with hospitals being such a high driver of cost. Outpatient, inpatient care is the most expensive and the biggest piece of that Medicare dollar or that healthcare dollar. So I think that's happening. You've got value-based care, and perhaps these are more buzzwords, but moving away from fee-for-service to value-based and prospective payments is something that maybe finally we're seeing a little bit. So I just wanted to be a little bit optimistic in in the context of this panel.
Can I say, 'cause I'll be the less optimistic, not less optimistic, the lost opportunity. I view it as you have these vertically integrated entities, plans, PBMs, often also now owning some type of direct care, where these efforts on PBM reform or hospital transparency are really just moving money around within the different operators, as opposed to ensuring that there's lasting benefit to patients. And so this latest drug pricing bill that the Democrats introduced included zero insurance reform. And so I'd hate to see, after all this pain and suffering, either with the IRA, CMS not implementing in a way that doesn't benefit patients, still allowing plans to charge 50% co-insurance for covered drugs, and prescribed drugs and prior authorized drugs, or through PBM reform, not doing more to say, hey, we're going to make sure that we're not just moving money between PBMs and plans that are vertically integrated, but actually ensuring that there's going to be some type of true savings for patients.
Yeah, and I think we also saw about a week, 10 days ago, FTC DOJ saying, look, we are worried about vertical integration, and they've actually increased or lowered their HHI thresholds to, assess a deal or potential merger as anti-competitive. So I think you will see a little bit more scrutiny, at least from the regulators, on the, kind of pay-viders. I hate that word, but I use it anyway. Owning up all the post-acute and doc groups, et cetera.
Last thing, but I do worry that CMS hasn't caught up to that. Like, they still don't understand how to apply the margin test or the MLR to vertically integrated entities, and at the same time not requiring that patients are actually beneficiaries see the true savings of what truly is the opportunity of care coordination.
Well, and I think, too, a concern is just overregulation in general. It doesn't allow for innovation in any sector, whether it's hospitals, biopharma, or others. And perhaps we should be looking more at models like Medicare Advantage that that show patients like those kind of models. That's where their feet are taking them when they have a choice, that's starting to look at outcomes and how do you make something like that work and work better, so that we're actually focused on quality and cost at the same time. All right, so I want to move on to talk. We've kind of talked around the edges a little bit about the difference between the a period that before small molecules are subject to being have their prices set, and large molecules. I remember when I first read the legislation, being the Pollyanna that I am, I thought it was a mistake, and I was wrong. And and we've certainly talked about so many patients benefit from small molecules because they're easier to take, and in some cases, as Dr. Gottlieb pointed out, treatments for behavioral health indications really are going to be in the small molecule space, but there are definitely disincentives for innovation in that area, or at least that is what has been purported. So Kirsten, is this a valid concern?
Absolutely, but there's the penalty on the small molecule.
The small molecule being the 9 years and the large molecule being 13 years before they're subject to
Absolutely.
price
large
setting.
molecules are already less subject to generic biosimilar competition. So you already had with large molecules, a potentially more expensive drug that didn't get super inexpensive generic competition once intellectual property protection and data protection ran out. And now you've further penalized small molecules, especially small molecules for the elderly and disabled. So look, small molecule technology is still going to be incredibly important, but if I were a company looking at unmet need and considering a development program, If I were thinking about the elderly, I would be leaning more towards a portfolio that was weighted towards large molecules, which again, where you're not going to see the kinds of savings you do from generics and small molecules. And then, for the non-Medicare beneficiaries, I'd be thinking more about development programs in small molecules. So it's going to have an effect. When drug companies make these decisions about what to invest in, it's unmet need and it's market potential. And you kind of put those two things on an axis, and then it's probability that you can actually develop the thing. So we've now introduced one more element into this technology that is relatively less expensive to develop and has great savings at the end of patent life. And we've said, well, now we're going to make this, put another hurdle in front of this for the elderly and disabled population.
I think we've already talked about the innovation piece and the shift occurring, but Ipsita, anything else that you want to add about what this really means for investment?
I mean, I think she kind of hit the nail on the head, right? Like companies are going to say, let's develop medications that are more for the commercial population, right? The non-Medicare population. There was a company yesterday that reported the quarter gene therapy company, BioMarin. They said, look, we are IRA proof. They've got a $2 million heme product, and who knows at the end of the day how wide the uptake will be. They do have competition in the space from CSL, but I think the mental health medication impact is a good one. It sounds like Scott hit on that this morning. I missed his comments, unfortunately. And as I think back to our spreadsheet of these 17 companies thus far that have made some very loud and proud announcement at ASCO, like Genentech and Novartis, who said that they were going to be discontinuing some oncolytic programs and projects, and then some other companies, Sage, some Alnylam, some other companies, big and small, that are saying the same thing. So I think the impacts are pretty real.
So Peter, at the end of the day, as we've said repeatedly, it's all about the patient. So what does this very short time frame for small molecules before they're subject to price setting mean for the patient?
One, the true harm is going to be the lack of new innovation that's we're not going to see until 5 years from now. There's going to be a giant drought, and all of a sudden Congress is going to say, what happened? What happened to all these new oncology drugs? What happened to all these new mental health drugs? What happened to the benefits of potentially of these new Alzheimer's drugs that can penetrate the blood-brain barrier that only small molecules can do? So that's going to be the one longer-term impact where people are going to say, it wasn't me, I wasn't here. But that's what's going to happen is there's going to be a desert in 5 years when it comes to new small molecule innovation. When it comes to actual other impacts, I mean, it just gets around, when Congress is prioritizing shots over pills, it means you're talking about a more difficult to manufacture, more requiring a physician and a higher copay, uncapped copay to deliver the product or the therapy. Then you're talking about something that's non-interchangeable at the pharmacy, and ultimately something that is it can be a lot more expensive when it comes to genericization versus a pill. And that is also something where, from a societal perspective, it's just silly when it comes to the negative impacts of this law.
And then to drill down on that a little bit, Ken, we look at the majority of the Medicare population having 3 or more chronic conditions. What does this mean for them?
Well, I think as everybody's been saying, it certainly means less innovation. And let's go back to the policy framework again. What policy, what potential, I can't even think, what were they trying to do here? I mean, what's the policy justification of having a 9 and 13-year differential? Because you're going to have a big impact on where steering capital, where it goes. I mean, why is the federal government getting involved in steering capital into Route B versus Route A? And I don't really understand what they're trying to do with that distinction. So I think, from a patient's standpoint, this is all an unnecessary mistake. We didn't have to do this. We could have saved Medicare money in different ways. We could have reduced what people pay out of pocket, take the MA model, integrate it into fee-for-service Medicare, for example, in terms of what people pay out of pocket. And it would have had none of these deleterious impacts on innovation. So it's just really an unnecessary mistake, I think, in terms of how we approached it. And we could have approached it just very, very differently without having the adverse patient outcomes and without having the adverse impacts on innovation.
Did y'all talk about the lawsuits yet?
on the lawsuits. So go ahead.
Okay, well, I'm not a lawyer, but I play one on TV, and there's about 6 of them, all kind of, initiated in various courts and jurisdictions. I think because at the end of the day, there's a hope that this could be a case that the Supreme Court hears, and I think that's actually fairly likely. Various constitutional scholars are saying, well, this amendment, this argument not going to go anywhere, this one might, but I think really there's a lot of well thought out arguments in those various lawsuits. There's one of them that actually has a preliminary injunction which would halt the law by October 1st. So as you know, the drug list is September 1st, but then 30 days after is when manufacturers actually, kind of sign on the dotted line to engage with CMS on the negotiation process. So I think that's why we see the October 1st date for the preliminary injunction. So I would just, put that out there as just another kind of thing that's happening in the landscape and in the background, is that, who knows whether any of these 1 or 2 or 3 suits will go anywhere, but I think if anything, it slows it down. And I think you've got an agency, CMS, that, this is hard for them. They don't know how to go about negotiating. And Ken was talking about rebates and fees and, DIR. It's such a complicated system. The agency has the dollars, I want to say it's $3 billion to hire a contractor to help with all of this. And, maybe it's a bit of a relief if this thing does get slowed down, because it's a huge undertaking. And I think about it a little bit like Part D, when the prescription drug benefit came around for seniors. Remember that year of, I think it was 2005, of kind of like the card, remember the drug card, and it wasn't all roses. It was a pretty bumpy implementation. So I think you could see the same thing here if and when it does go forward.
Good point. All right, let's, anyone in the audience have a question? Otherwise, I have more.
Yeah, so a couple of comments, actually. Thank you. So first, everybody's talking about the small molecule or biologic distinction, and in cardiovascular medicine, our 2 greatest innovations in the last several years have been with the small interfering RNAs and the antisense oligonucleotides, both of which are injections and both classified as small molecules. So they are going to be hurt, and that's where we are, doing most of our work. That Lp(a) program I spoke about earlier is actually both of these mechanisms of action are being utilized. So that's one thing. Another thing is, we all talk about the patient. We care about the patient. I just want to remind everybody here, sadly, that we are all patients. So when we talk about the patient, we're talking about ourselves, and I think that feeling, maybe when we genuinely understand that, it's fairly powerful. And then finally, just cardiovascular medicine. I want to have the opportunity to emphasize that cardiovascular disease is still the #1 killer in the United States. Greatest morbidity associated with it as well. 40+% of Medicare patients do have established cardiovascular disease. And cardiovascular disease is more vulnerable, actually, than other disease states. All disease states are important, but it's more vulnerable to the IRA because patients are older, our studies are much longer, much more expensive. We use more small molecules than any other disease state, and cardiologists tend to be slow adopters of drugs. So pharmaceutical companies cross that threshold of profitability much, much later in the life cycle of development than other drug classes. And somehow, if we can emphasize that and make everybody understand we're all patients, we're all going to have this disease, and we better do something about it, perhaps that would be helpful. And I don't know how to do that other than saying what I just said, but maybe you guys have some good actionable ideas.
Yeah, I think it goes back to what I was talking about earlier, that we all have personal stories, and I think sharing those are always helpful. My husband was diagnosed with type 2 diabetes several years ago. He went on some medication, had some pretty annoying side effects, quit going to the endocrinologist, quit taking the medicine. Finally, his A1C creeped up to a point where he had to go back Luckily, there were new medication options for him that didn't have the same side effects, and now he's back on medication and he has controlled type 2 diabetes. Had he gone back and there hadn't been any other option, I can guarantee you he would have just said, forget it. So that's just one story. I think we all have them. So in our remaining couple of minutes, just quickly down the line, this panel is called The List and Impact on the Healthcare Ecosystem. So any parting thoughts that you have on what the impact is and what you want everyone to take away today from a healthcare ecosystem perspective. Kirsten?
I just remember it's more than a list. It's every single drug in Medicare. And also, I think something we didn't discuss as much today, which maybe we will on a future panel that Candace will organize for us, is the seismic change that's happening in health plans. And so goes the health plans, goes our access to medicine. Remember, rebates are going away to a huge extent. The insulin rebates were huge, helped reduce the premiums. The plans are going to have to figure out other ways to remain profitable without rebates, and that's going to be access restrictions. And we need to be, and that's all the medicines, not just the medicines on the list. So I think really focusing on how many plans are exiting the markets, what kind of access we have to medicines, both on the list and off the list, is going to need to be a top priority, because we can't assume that CMS is going to take care of that for us.
Ipsita?
Well, we've already seen impacts to innovation, clinical trials being halted, various programs being diverted to maybe a larger cancer indication versus a smaller one. And I think we're just going to see more and more of that. I hope that Congress is aware of that. And then, we talked about this a little bit in the panel, but I would just emphasize that a lot of what Congress is doing and has been doing for many years is a bit of a whack-a-mole, right? We're going to get the drug industry in 2022, and then we'll get PBMs and then hospitals. But this idea of systemic reform, I think, is really needed. And, we're taking some baby steps in the right direction around value-based care and some other payment pilots and some innovations out of the private sector. But I'm hopeful that things will move ahead.
I think obviously echo today's panels, not just our panel, about wanting to make sure that this law is actually implemented in a way that benefits patients. And I just want to, rather than sort of repeating what I've said before in terms of what everybody said, I just want to highlight the next shoe to drop, which truly is going to be the effort by ICER to basically codify their version of cost effectiveness into IRA implementation. And that impacts all of us, because we are all patients and we all want medicines that actually not only benefit the health plan for that plan year, but actually help us as patients and society in general. And so the more that their math can be improved and fixed and updated so that it reflects not just the plan year math, but actually takes into account real world values, like that a drug goes generic, that there's going to be therapeutic competition, that there's going to be population growth, that there are benefits to these innovations around caregiver spillover, being able to go back to work. These are all things that ICER and CMS does not want to take into account, that are quantifiable. And then as looking ahead, that's going to be the next thing that I think all of us are going to have to work together to make sure it doesn't somehow inappropriately limit patient access to these new innovative medicines.
Ken, final 30 seconds?
Yeah, no, I think that's well said. I'm not giving up the ship here. I would hope that we could take a step back. And, I think I got a headache after this panel now. We have a combination of ICER and regulation. And, boy, those are both wrong directions. I'm not a cheerleader for MA, but it's a movement in the right direction. There's problems with it. There's issues and challenges. But at least they've got the right framework. You're really looking at per capita spending over the course of a time period. There's incentives in there to innovate. There's incentives in there to provide better care coordination. Who cares if you spend more on drugs, if you save it on the hospital side? That's the right perspective. The other 50% of the world, we're in silos. All right, listen, as Ipsita said, let's whack down the drug side, and, something else is going to pop up. Let's take care of that. It's really, from a policy standpoint, a really bad way to think about reform. And so, the combo of sort of European-style price regulations and ICER, boy, that's enough to keep me up all night just thinking about that prospect, when we have a very good model in place for 50% of the Medicare population already. So, this was unnecessary damage, wrong response, fixing no underlying problem, so it doesn't fix anything in terms of the system. I just think we're going in the wrong direction with this, and I would hope we could take a step back and work with staff and work with others and say, we don't have the right perspective here. It really is per capita spending that we should be focusing on. It doesn't really matter if we spend more in this silo and less on this silo. It was more efficient, and it provides better outcomes for patients. And I think until we get to that, we are going to continue to play, whack-a-mole. I'll just close by just saying if you go back and look at the data on where we spent money on healthcare back to the 1980s, about 40% of it is on inpatient hospital care. Today it's about 20. Could you imagine if we had a system that regulated each silo at some particular level and had to grow it 2-3% per year? We would have had zero innovation because you've locked into place 1980. The innovation happened because of the movement to ambulatory surgery and different types of procedures that came out of the hospital to outpatient settings. Well, that's because we're not sort of doing regulation by silos of care. And so we've got to get out of that mentality, and I think until we do, we're just going to continue to inflict unnecessary damage on patients and on the system. So hopefully that's leaving it all on an optimistic note, but I think that there's a direction and we have an approach out there that half the program is enrolled in.
Exactly.
Could I ask one more question? I'm so sorry, but I do want to, I haven't heard anything about this. I've read about direct and indirect loss of jobs, a million people perhaps in the pharmaceutical industry. So there's that background. Do you think that biopharmaceutical companies are going to move out of the United States as a consequence of this act?
Well, I think we heard this morning from Scott Gottlieb that we're definitely going to see more drugs introduced off the U.S. coast, and so that's, potentially means employees as well, I think. Anyone else want to add?
Yeah, I think the challenge,
Right.
I mean, the tax structure externally, in Europe and versus here is quite different.
Yeah.
So while now you may have more launches externally, I mean, certainly the tax incentives are quite different.
Are different, yeah.
I think the another way to answer that is there are a lot of countries that would like that to happen. Like China would like that to happen.
Yeah.
So, and even Europe would like that to happen.
And they might help make it
I think
happen,
it's
yeah.
less. I don't think it's less easy to say that now what that impact's going to be, but we know that our economic competitors would like that to happen.
All right. Well, thanks to this terrific panel. In closing, I would just say, as Candace mentioned, our members are CEOs from all different sectors of healthcare, and I'm frequently asked, well, did your entire membership oppose the IRA? And the reason that they did and the reason that they're concerned is because of the impact to the entire healthcare ecosystem and the innovation that would be lost. And to Ken's point, this is really about how do we look at healthcare delivery in a way that focuses on outcomes, on better coordination of care, on value-based care, as Ipsita talked about. And this doesn't do that. And that's why we were able to bring our entire membership together on this issue. So thanks again to our great panel, and have a great day. Ken, I think you're closing for us.
Yeah, and I'll just go ahead and close from the partnership standpoint. Thank you for Levitt Partners for having us here, this wonderful facility. More importantly, thanks for all of you for coming and listening to us woe and complain about what's going on. But I think there's some real challenges and issues here that I think if we sort of move in the right direction, we can effectively address. So, like I said, I'm not giving up the ship yet. We can take a step back and really look at this in I think a different way, and hopefully we will. So thanks, and I appreciate y'all for coming. Have a great day.